We go. Ready? Hello again and welcome to the KCCMH Connection. I'm your host, Eileen, and we are joined today by Dr. Alex Ende, a gastroenterologist with South Denver Gastroenterology who sees patients right here at KCCMH Specialty Clinic. Dr. Ende completed medical school and internal medicine training at the University of Pennsylvania before going on to complete his fellowship and advanced endoscopy training at the University of Washington. His clinical interests include colorectal cancer screenings, Barrett's esophagus, endoscopic ultrasound, and advanced procedures such as ERCP. In addition to caring for patients, Dr. Ende has conducted research on colonoscopy techniques and gastric intestinal metaplasia. Did I say that correctly?
You got that right. Yeah, absolutely.
And he believes in treating every patient the way he would want his own family to be treated. Welcome to the connection, Dr. Ende. How are you today?
I'm good, thanks. Thanks. Excited to be here.
So first question we love to ask is, what drew you to gastroenterology as a specialty?
Yeah, so it's gastroenterology is a subspecialty of internal medicine. So I sort of started by knowing I wanted to do internal medicine. And that to me just always felt like what a real doctor, quote unquote, was to me, as somebody who kind of took care of the whole body, could see younger patients, older patients in the hospital, out of the hospital. And then I learned in internal medicine residency that I really loved doing procedures. So within internal medicine, GI is probably the most procedure heavy field. And I rotated through GI. I loved the idea of colon cancer screening, the idea of being able to identify precancerous polyps, remove them before people ever develop any issues from them, to ever develop colon cancer, and keep them healthy. I also just love working with other gastroenterologists. I found them to be a really kind of lighthearted bunch, funny, didn't take themselves too seriously. So that kind of sealed it for me. And I kind of decided probably end of my first year of internal medicine that that's what I was going to do.
Oh, that's fun. So are you saying there's some sort of commonalities between gastro doctors?
I think so. I mean, most of us, you spend a lot of your day doing procedures on people's colons, and you have to talk about gut issues, and sometimes the patients are a little uncomfortable talking about it. So I feel like you've got to be really comfortable talking about it and help put people at ease. So I think it just sort of attracts that kind of personality. It tends to be good people, not a lot of big egos in GI.
So that kind of spins into our next question, is that your patient care philosophy is to treat patients the way that you want to be treated. So what exactly does that look like in your practice?
I think it means listening well as the first thing. Most of the time, I think when people come to see not just a GI doctor, but any doctor, they have an agenda. They have some symptoms, some complaints, things they want to talk about. So I think the first thing is just listening. I try not to interrupt people, let them explain exactly why they're here, what's been going on with them. And then I always have follow-up questions. But I think the best thing doctors can do is to listen. Obviously, patients are there to get your opinion as well and your expertise. But if you're cutting them off, if you're not hearing everything they have to say, you're probably not getting the whole story.
Mm-hmm. And just kind of build the trust with the person, get to know them.
Yeah, exactly.
So colon cancer is one of the most preventable cancers when caught early. So that's obviously why screening is so important. But what do you say to people that avoid screenings or don't think they need a screening?
Well, we get that question a lot. The most common things people will say is, well, I don't have any symptoms, or there's no family history of colon cancer in my family. And the thing I think it's important for everyone to know is that colon cancer oftentimes has no symptoms, and certainly colon polyps, which are the little precancerous growths that turn into colon cancer, definitely do not have any symptoms. So almost every day I do a colonoscopy on someone and remove a precancerous polyp that they never knew they had. It caused no symptoms. They were not noticing any rectal bleeding. They were not noticing any pain, but the polyp was there nonetheless. So it's not something that you necessarily would have symptoms for. And I think the other thing to take home is that people understandably have a lot of anxiety about going through a colonoscopy. They're concerned about the invasive nature of it. They're concerned it's going to be painful. They're concerned about the bowel prep. And by far, the most common thing we see in the recovery side after someone has had their procedure is, wow, that was really not that big of a deal. The prep can be challenging, especially for some people, but the preps actually have gotten a lot better in the last couple of years. We now have a pill-based prep, so they're not drinking as much of the gross tasting liquid that some people remember from their prior colonoscopies. And the anesthesia for the procedure works great. So we use a drug called propofol. Patients are asleep. They're comfortable. They're not, they don't require a breathing tube. They're still breathing on their own, but they're completely asleep. And people wake up and they say, that was the best nap I've ever had. Can I please have some propofol to take home with me? And we always say, no, sorry, we don't have to-go bags, but people really do find it's not a painful procedure. It's not an uncomfortable procedure. And then on the other side, if you told them, oh, hey, by the way, you had a couple colon polyps, I removed those, they could have turned into colon cancer if you hadn't come in to get this done. Usually they feel really good that they went ahead and did the procedure. And oftentimes they're the first people to recommend the procedure to their family, to their friends, because they see the power of doing a colonoscopy and preventing colon cancer before it ever has a chance to cause issues.
So let's go back to the prep for a minute then. What is prep? What does that look like? How many days is it? What's required? Because I think if maybe we can inform our public and give them the whole picture, that maybe they'll realize that it's not as scary as it comes across possibly.
Yeah. So the prep usually starts about the 24 hours before the procedure. So the day before the procedure, you're on a clear liquid diet. So meaning you can have things like Gatorade, bone broth, nothing solid. And the reason is that kind of starts to empty things out. And then the prep, there are different ways to do it. I know at Kid Carson, they tend to do a Miralax prep, which works well. And that's essentially an over-the-counter laxative that you mix in with a lot of liquids. And it's going to give you a lot of diarrhea. That's the way it works. That's kind of the only unpleasant side of things. We also, as I said, do have pill-based preps. We have other kind of what are called low-volume preps. So it's not drinking a full gallon of gross-tasting liquid like it used to be. So you start typically the first part of it the night before the procedure, the second part of it the day of the procedure, typically about 8 hours before you're scheduled. And then by the time you're done the prep, you're totally cleared out. And the reason that's important is that when I go and do the procedure, I'm looking for really small polyps, sometimes as small as 1 to 2 millimeters. And we need to make sure that there's no stool left in your colon. It's completely cleared out so that we can get a good exam. What's really we try to prevent is if people don't do the prep right or they're not completely cleaned out, then sometimes you can go and do the exam, but you can miss things. And then you have to tell them, well, I can't give you 10 years to come back for your next one. You got to come back in 1 year or 3 months. So we try to just do it right the first time. It really is worth putting in that effort so that we can get a really good exam and hopefully tell you, you are good for 10 years, and you can kind of go home with that peace of mind.
So the prep is pretty important then.
The prep on the patient side of thing is by far the most important thing. That's kind of the only job we give to the patient is doing the prep. Apart from that, when you come in for the procedure, as I said, you're basically taking a nap. We put an IV in your arm. We talk about the procedure right beforehand, go through the consent process, but then the anesthesia kicks in, you're asleep, and you wake up pretty quickly afterwards. The propofol wears off very quickly. So that side of things, the patients really tend to have no problems with whatsoever.
And then what does recovery look like? So obviously you go home the same day, but is there anything, any sort of concerns people might have about returning to work right away?
So we always tell people you're technically impaired the rest of that day because you've had anesthesia. So for that reason, you do need somebody to come with you to the procedure because you can't drive yourself home afterwards. So
Okay.
we tell people the rest of that day, just sort of take it easy. It's a good day to hang out on your couch, watch some TV, no alcohol, things like that, no other sedatives, because you technically do have anesthesia in your system. Most people realistically feel pretty back to normal by the time they leave because the propofol wears off in minutes. But the next day, you can go back to doing whatever you want. You can go back to work. You could drive a car the next day. So yeah, apart from that, it's a pretty easy procedure. And as you said, an outpatient procedure. So in total, you're kind of giving up about a day just to get this done. But most of that day is just sort of spent hanging out on your couch, doing whatever you want.
Okay. So
Yeah.
now that we know why we need it and how it's done, who needs this?
So everyone should have a colonoscopy starting at age 45. It used to be we started at 50. A couple years ago, we lowered that age to 45. And that's because we're starting to see colon cancers in younger people. And unfortunately, despite all of our efforts to get people screened for colon cancer, it recently became the number one cause of cancer death under the age of 50. And as you said, it's
Oh, wow.
entirely preventable. So we have a lot of work to do, especially in rural areas where people may not have, always had the easiest access to colon cancer screening.
Hmm.
That's part of my passion. That's part of the reason I'm so excited to be coming to Burlington is to help introduce a procedure like screening colonoscopy to a population that, maybe didn't have the easiest access to it. So 45 is when everybody should start. The other thing I think everyone needs to take home from this is that if you're having symptoms like blood in the stool, abdominal pain, losing weight, change in bowel habits, that's a reason to talk to your doctor no matter what age you are. We unfortunately are seeing colon cancer even in people in their 30s. So if someone is
Wow.
having blood in their stool, it's really important that they not ignore it. A lot of times this stuff gets attributed to just, oh, you probably have hemorrhoids. No big deal. Don't worry about it. But until you've had an exam, and probably a full look at the colon with a colonoscopy, I always tell people you can't just assume it's hemorrhoids. So age 45, symptoms, or if you have a family history of colon cancer, that's also worth talking to your doctor because in those patients, sometimes we'll start screening early as well. And then there are some conditions, some things like Crohn's disease or ulcerative colitis where we might start screening earlier. But again, those are all conversations to talk about with your doctor. I think that the main thing to remember is 45 years old or symptoms or family history. Talk to your doctor about getting a colonoscopy.
So, Dr. Ende, do you know why that there's an increase in seeing this cancer in younger people? Is it diet? Is it chemicals? Do you know what's happening there?
It's not totally clear. It's a hot area of research for a lot of people. There's thoughts that maybe it's related to processed foods. It could be related to obesity. It could be related to things like alcohol. There's even thoughts that maybe there are certain bacteria that are living in the colon now and leading to colon cancers forming. It's not totally clear. I think we're going to learn a lot about this in the next couple of years, but for right now, it's still a hot area of research.
Okay, so something though that people should just totally keep on their radar.
Yep, absolutely. And as you said, it's preventable. There's not a lot of cancers that are 100% preventable, and colon cancer is one of them.
That's incredible. So what are what are other most common digestive issues that you see in your practice?
So the other thing we see a lot is acid reflux, really any swallowing issues. So acid reflux is obviously very common. That's something it's worth seeing a GI doctor, or at least talking to your primary care doctor about, because that can actually be a risk factor for esophageal cancer. So that's something that we'll oftentimes do a procedure called an upper endoscopy, where we go through the mouth, look at the esophagus, the stomach, and look for any precancerous changes, which are the result of acid reflux. But really, GI covers a wide area. So it's everything from reflux, swallowing problems, abdominal pain, liver disease, anything involving the pancreas, inflammatory bowel disease. That's really a long list of conditions and symptoms that we can take care of as gastroenterologists. So that's one of the things that kind of makes it challenging. You're not just doing one thing all day. It also makes it fun. You're taking care of a lot of different things. You're taking care of a lot of different organs as part of your job.
Yes, and things that cause people so much discomfort too. And so A lot of people experience chronic heartburn or acid reflux and maybe just take the over-the-counter medicines to mitigate the feeling of it. But what are some
Sure.
things that they should not ignore, or like when is it time to seek next level of
Yeah.
help?
I would say if you're at the point where you're having daily acid reflux or having to take a medication every day and it's been more than a few weeks or months, that's a good point to talk to a gastroenterologist. The risk factors for Barrett's esophagus, which is precancer, the precancerous change I was mentioning, tends to be people with longstanding acid reflux. It's more common in men. It's more common in people with obesity. So anybody who fits that category, definitely worth talking to your doctor about. The other thing we consider alarm symptoms are a swallowing problem. So if you're feeling like you go to eat and food is getting caught, that's a reason to talk to your primary or a GI doctor. Weight loss or blood in the stool or black tarry looking stools, because those can be signs of cancers as well, and need to be investigated.
Okay. So you've been in the game for a while. What are some advances in endoscopic technology, patient care that have changed over the years?
So there's a lot of things that we do now as gastroenterologists that used to be handled by a surgeon. And the main thing is, I would say, the thing I probably see every day is removing large colon polyps. That's something I have a lot of experience with, enjoy doing a lot. And essentially, it's large growths in the colon that are maybe close to turning into a colon cancer that a few years ago you would have sent to a surgeon to have that part of the colon removed. And now we have techniques where we can just remove those right there during the same colonoscopy and prevent someone from needing a surgery.
Oh, wow.
There's similarly, most advances in GI are things that used to require surgery and now can be done all endoscopically, which is obviously much less invasive. Things like removing stones from the bile duct, biopsying areas of the pancreas or even outside of the GI tract. All of those are newer techniques, I would say, in the last 15, 20 years that used to require a trip to the OR.
That's incredible. So you're able to save more of the colon itself then through these procedures than
Right.
previously?
And yeah, so if you're removing a polyp, you're not really removing a part of the colon, you're just removing the polyp itself. So yes, you're preventing someone from having part of their colon removed, but you're also preventing them from having another surgery. So people will come in for their routine screening colonoscopy and you can remove the polyp right there rather than saying, you need to come back, do another prep, talk to a surgeon, book a date in the operating room, probably have a night or two in the hospital in recovery. Right now, it's just all done right there during the colonoscopy.
That's incredible.
Yeah.
So you perform procedures like ERCP and endoscopic ultrasound. In simple terms, what are those procedures used for?
So the ERCP is a procedure that we do to essentially remove things or place stents into the bile duct or occasionally the pancreatic duct. So this is again something that you do through the mouth. And oftentimes what we'll see is stones from the gallbladder will get stuck into the bile duct. And those patients will often have abdominal pain. Their liver tests will become abnormal. Sometimes they'll notice yellowing of their skin or eyes. And that procedure, we can go in, go down past their stomach, remove those things from the bile duct, and oftentimes put in a little stent to help the bile drain out. EUS stands for endoscopic ultrasound. That's a procedure that mostly is done looking at biopsying things in the pancreas. So the pancreas sits right behind the stomach. So again, by going through the mouth down into the stomach, we use a little ultrasound probe to look at these areas, whether it's a mass or a cyst, and we can put little needles through the wall of the stomach or the small bowel to get some tissue. And again, it's sort of a minimally invasive way of getting samples from the pancreas that previously would have required going to the operating room.
Okay, I'm starting to understand your interest in doing the procedures.
Trend.
There's a lot that you can do. That's very cool.
Yeah.
So what does it mean to you to provide specialty care in rural communities like ours? I know that you said you have an interest in bringing it out here, but can you tell us kind of like how you ended up joining our specialty clinic, or
Sure.
what your rural outreach looks like?
Yeah. So I started, this was actually early when COVID first started, going to Goodland just over the border in Kansas because they had been looking for a gastroenterologist. And I've started, and I'm still go out there 2 days a month to do procedures, see patients in the office. And I just absolutely fell in love with working in a rural community. It really just provides an incredible sense of satisfaction to go out there and take care of someone who, as I said, may not have had access to a gastroenterologist. So I ended up starting a practice with a friend of mine who does something similar in Hugo, Colorado. And we call it GI Community Solutions. And essentially what we're doing is trying to pair up doctors who tend to be practicing full-time in Denver with a more rural community where they go out 1 day a month, do all of the same things that we do on our day-to-day practice in Denver. But the idea is sort of bringing the healthcare to the rural community, not because patients can't go to Denver or get in their car and drive for their procedure, but the reality is people are busy and it's hard to expect someone to meet with a doctor who's hours away where they may need a long car ride. Similarly, come back for a procedure. And we just think it makes a lot more sense to bring the doctor to the community. And oftentimes, 1 day a month is sufficient. So in that time, they can see the people who need their help. We can do the procedures in the community. That way, the hospital is not having to send all their patients out to a Denver or to Colorado Springs or to a larger city. We can take care of all of their population right at home. So it's been a great success. I think the patients like it, the hospitals like it. I can tell you every doctor who has started going out to a rural community through us just absolutely loves it. We haven't had anybody stop going because for me, it's honestly, it's the best day of my month when I get to go out and just do something totally different, take care of a totally new group of patients. And that's why I started coming to Burlington because I love it.
Oh, that's awesome. And
Yeah.
I know, we know too that patients are capable for many of them of getting to Denver and doing all those things, but we kind of like to think that, that your health happens best when it's close to home and familiar faces. And so we're so happy that doctors like you're willing to bring your skill sets out here and help us.
Yeah. No, I mean, it makes, going in, getting an appointment, seeing the doctor, especially doing a procedure, there are hurdles to doing it even when you live close by. So why introduce another hurdle of asking someone to get in the car and drive 3 hours when they don't have to? So I think it's a win-win for everyone. And I think it makes total sense. So no plans to stop doing rural medicine anytime soon.
Awesome. So what's one thing that you wish all your patients knew about your field of practice, like either about taking care of themselves or what you can or can't do as GI?
I think it's that we're not just diagnosing things, we're preventing things. I think that that's kind of been the advancement in GI in the last couple of years, that it's not the doctor who goes and finds out that you have esophageal cancer or colon cancer. It's that we can do things that prevent them from ever happening in the first place. So I think especially, there are other tests now that look at for colon cancers, but I think what gastroenterologists really can offer is the prevention side. And that to me, that was, as I said before, is one of the big draws for me for GI, is that we can help prevent things. So I think it's worth investing in your health, getting some of these things done so that you never run into issues down the road. That would be, I think, one thing I would love people to take away from this is just it's worth being preventative even if you don't have any symptoms, because it's much better to prevent disease than from treating it down the road once it happens.
Yeah. I think it's really great that you mentioned that, because through this series, pretty much every doctor specialty has said the same thing, that the biggest advances are coming from learning how to prevent these things in the first place.
Yep. Absolutely. It's better for the patient. It's better for the healthcare system as a whole, obviously, to keep people healthy, to keep them out of the hospital. So, and I think we're getting better at it. But as I said before, we got a little ways to go, especially with colon cancer.
So in terms of prevention, what are some of your top takeaways? How can people prevent needing your services? Now, I mean, you can't always prevent it, right? Because some people are born where things develop, but like, how can we What prevention do you offer?
So I think the best things people can do for themselves are stay active, stay healthy. And by staying healthy, I mean stay physically active. A little bit of exercise, even for things like fatty liver disease, which is something else we're seeing very commonly. We're learning that even just say 30 minutes of exercise a couple times a week goes a long way in helping your liver kind of shed that fat, stay healthy. I think there's good evidence that being physically active helps to prevent even colon cancers. The other thing is just keeping on track of your diet. So trying to limit too much processed foods, limit fast food, and making sure you're getting enough fiber. Americans especially are definitely not getting their fiber. So whether that's increasing the fresh fruits and vegetables, whole grains, or even doing a fiber supplement like a Benefiber or Metamucil, which is available at every pharmacy, that is incredibly important for gut health and for colon cancer prevention.
Okay, so another thing, now that you mentioned that, supplements that we hear about are like prebiotics, probiotics. Are they buzz things, or are they legitimate?
I think they're legitimate. I don't think everyone needs to be taking a probiotic. And essentially what a probiotic is it's a way of delivering what do we think of our good bacteria to your gut. So your gut has about 40 trillion bacteria. There's more cells in your gut than there are cells with your own DNA in your body. So you have more foreign cells in your gut than you do in your own body, which is kind of amazing to think about. Your gut microbiome will stay healthy and diverse just with a good balanced diet. So I always tell people when you go to the grocery store, think about eating the rainbow, meaning, mixing in different colored foods, red peppers, beets, things like that. All of those fresh fruits and vegetables are going to give you a good, healthy microbiome, and then you won't need a probiotic. I do think it's helpful in some cases if you've had to take antibiotics recently. Taking a probiotic can help kind of kickstart the good bacteria in your gut, or if you've been sick, you had a virus, say, that was causing diarrhea, a probiotic can be helpful afterwards. But I don't think it's necessary for everyone all the time. I think you can get all the benefits of it with just doing a well-balanced diet.
Okay, that's great to know. So
Yeah.
on the flip side of that, is there anything like the gut absolutely does not love or won't serve you well? Okay, for example, like the hot, spicy chips and things that the kids love to
Sure.
eat.
Yeah.
Are those bad for
I
you?
think that, well, too much processed food is definitely not healthy for you in general, and not just for gut health, but kind of overall heart health, and limiting processed foods is definitely a good idea. There are a lot of foods that in people who have, say, acid reflux, doing a lot of spicy foods, onion, garlic, caffeine, alcohol, all those things can trigger acid reflux. I'd say if you don't have reflux, if you don't have symptoms from it, it's probably not something you need to worry about. But especially in people who have reflux, those are things that they should avoid. Other things we see people get into trouble with are some over-the-counter medications, especially like ibuprofen. So like Aleve, Excedrin, Motrin, all of those things can cause a lot of irritation in the gut. They're the number one cause of ulcers. So oftentimes we see people come into the hospital with abdominal pain, or they're bleeding from their GI tract. Oftentimes it's the non-steroidal anti-inflammatories like ibuprofen that cause that. So those in small quantities occasionally are probably safe, but people who are taking a lot of them or for long periods of time can run into big problems with that.
That is very interesting. I had not heard that. Okay,
Yep.
That's really great to know. So lightning round, fact or fiction? I feel fine. I probably don't need a colonoscopy.
Fiction. You need a colonoscopy if you're 45
Okay.
or have any of the other things I mentioned.
Yes, and I know that we have covered that, but I think we probably can't cover it enough. It sounds like that because the service that you can provide can prevent so much hardship down the line that we have to keep saying it.
Yep, agreed.
Yes. Let's see. What's one thing patients, oh yes. So again, just talking about reduction of the risk of colon cancer, we need to eat better, exercise more, maybe limit our NSAIDs if possible, get screenings, anything else.
I think don't be afraid to talk about your symptoms with your doctor. People have a tendency, especially in the GI world, to ignore things. Maybe they've noticed blood in their stool. They either don't think it's a big deal, they're a little bit embarrassed to talk about it. I would say this is what, certainly what I do all day. Your primary care doctor is very used to having these conversations too. Don't be embarrassed. Go see your doctor. Don't hide your symptoms. Make sure you talk to someone about them.
I think that's wonderful advice, because I do think that a lot of the concern around this just comes from, it's a very private area. It's a sensitive issue. It's not something you bring up at the dinner table. So, but it's good to remind people that this is your job, and nothing they say is probably going to shock you.
Yep. That's right.
So is there anything else that you would like our listeners to know about you, your practice, what you do, the services that you provide here at KCCMH?
Yeah. So I'm going to be coming out one day a month. Right now, we're planning on the first Thursday of every month. I'll be doing probably a mix of consultations in the office and procedures. So happy to see people for either. Some people, will need an office visit to talk about symptoms, but I'm also just going to be doing regular procedures that maybe their primary care doctor orders. You may just be meeting me for the first time when you need a procedure, or you can come see me in the office. But it's first Thursday of every month, and happy to come see anybody for any GI issues they have.
So what kind of procedures can you perform here in Burlington?
So we'll be doing upper endoscopy and colonoscopy, and that really covers, I would say, probably 95% of what most people will need anyway. So some of the other, so the colonoscopy is by far probably the most common procedure I do, just because it's the one that everyone needs at some point. Upper endoscopy is, again, very common. The other procedures, endoscopic ultrasound, ERCP, that's a little bit more specialized equipment. So that, I'm happy to see people in Burlington if they need one of those procedures, but that would be done in Denver. But again, that's much, much less common. I would say 95% of what most people will need, we can absolutely take care of in Burlington.
Oh, that's really great. And what ages do you see?
So really anybody 16 or older. I'm not a pediatrician, so I don't take care of kids, although, there are some good pediatric GI doctors in Denver. But 16 or over, really anybody for any GI issue.
That's great to know. So let's stay there around the teenagers. What kind of issues do you see with like the much younger population?
So 16 is sometimes we see people being diagnosed with inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis around that time. So you'll get, sometimes people will notice blood in their stool, diarrhea, but it can really be anything: nausea, abdominal pain. Teenagers can have a lot of these issues too. And it's funny, a lot of people are surprised when I tell them I see a lot of young patients, because they assume that everybody I see must be at least 50 years old, but we see a lot of younger people. They can have these issues too. So it's really tends to be inflammatory bowel disease or other symptoms. Obviously at that age, we're not typically doing routine colon cancer screening, but it tends to be more symptomatic based.
Okay. Yeah. I know that sometimes, again, we don't all understand the things that our specialty doctors are capable, the procedures, who they can see, what people should be seen for. So thank you very much for talking to us and just letting us know that you're here, what you can do, who you can see.
Sure. Happy to. Yeah. No, I'm excited to be starting.
Yeah. So before we go, why don't you just tell us about Dr. Ende, the person, instead of Dr. Ende, the doctor? What do you like to do in your free time? Do you have a family?
Yeah. So I have a dog and a fiance. So I'm actually getting married in October.
Congratulations.
Oh, thank you. I love to really do anything outside. So that was one of the things that drew me to Colorado. Is I love to ski. I love to mountain bike. I'm training for the Leadville 100 mountain bike race this year. So when I'm not working or traveling, I'm usually on my bike or trying to get in a couple of days of skiing. I love exploring the restaurants in Denver. But yeah, I tend to be outside when I'm not at work.
That's awesome. Yes. Well, thank you so much for taking the time to talk to us. And we are going to link the phone number to the specialty clinic in our podcast. So if anybody has any GI concerns, they know how to get a hold of you through our specialty clinic. And we'll see you, let's see, because you already had your day here for June. So we'll see you back in July then?
Yes, I think it's July 2nd. I'm there again.
I think so.
Yeah.
Okay.
Great.
Well, thank you so much.
Thank you. Pleasure.
Okay, well, we will see you guys next time on the KCCMH Connection. Talk to you later.